Assalamu alaikum. Today we will start our first lecture in respiratory ECMO or veno-venous ECMO. And if we speak about the first lecture, we will start it with patient selection, which include indication, contraindication, and prediction of mortality. As we mentioned before, we have two types of ECMO, veno-arterial ECMO, which is called cardiac ECMO, and veno-venous ECMO, which is a respiratory ECMO. For veno-arterial ECMO, when we have starting to have ejecting heart, good ejecting heart, but the lung is not recovered yet, so we will have differential hypoxemia. At that time, we should shift the patient to veno-venous ECMO. So veno-venous ECMO is used for the patient who improved from veno-arterial ECMO. The heart is improved, but still there is delayed recovery for the lung. Or from the start, we will use veno-venous ECMO for patient who has resistant hypoxemia, and we will explain that later. So what are the indication of veno-venous ECMO? For patient with resistant hypoxemia, if the patient is candidate for lung transplant or other chance for recovery. So for recovery, we give the patient time to rest the lung, and for lung transplant in end-stage lung disease, who accepted for lung transplant. So the question will be, why ECMO for recovery? It will avoid direct harm to the heart, to the lung. So avoid high FiO2, high volume, or high pressure. And at that time, we will have high FiO2, which will be mixed rapidly with the patient system. So it will increase SpO2 without causing any harm to the lung. Lung for recovery, like ERDS, it's very common, the most common use of ECMO for VV ECMO for ERDS. Acute exacerbation of COPD, severe ear leak, post-thoracic surgery, acute airway obstruction. Second thing, lung transplant, it depends on each center experience in the stage chronic lung disease, interstitial lung disease, cystic fibrosis. Also in patients with primary lung graft dysfunction, it can be used till healing of the lung. What is the timing for VV ECMO? We should first do everything for ventilation parameters. Low tidal volume, treat ventilation dysynchrony, titrate the PEEP using neuromuscular blockade, prone position, inhaled vasodilator. We can do lung recruitment and inverse ratio. In this diagram, we put stepwise approach for the management of patient with severe ERDS. And here we will find the ECMO at the top of the management after fulfill all different management from high PEEP, prone position, neuromuscular blockade. So the last destination is ECMO. Then when we will go for ECMO, based on Caesar trial, Murray score more than 3, and we will use in Murray score chest X-ray, PEEP, lung compliance, PO2 to FiO2 ratio, or pH less than 7.2. The most common criteria used these days is Aeolia trial, which use PO2 FiO2 ratio less than 50 mm mercury for more than 3 hours, or PO2 FiO2 ratio less than 80 mm mercury for more than 6 hours, arterial blood pH less than 7.25, and BCO2 more than 60 for more than 6 hours. What are the contraindications for ECMO? Absolute contraindication if there is a pre-existing condition that's incompatible with recovery, severe neurological injury, and stage malignancy. The relative contraindication, uncontrolled bleeding, very poor prognosis from the primary condition, if there is mechanical ventilation more than 7 days, if the patient is cardiogenic shock, so we should go for VA ECMO, or septic shock with multi-organ dysfunction. What about patients who have shock? If we have patients who have shock, so it's a contraindication for ECMO? No. So any patient before using VV ECMO should have echo. For example, patient with septic shock, and this septic shock due to pneumonia or infection in the lung, and the cause of primary is respiratory failure, and the patient in low to moderate dose of vasopressors, he is a candidate for VV ECMO. But if the patient is on high inotropic support and having multi-organ dysfunction, this is a contraindication for ECMO. Why? Due to survival issue. Also, patient will not give benefit from VA ECMO. For patient with acute RV failure, we should know that if they have acidosis, hypoxemia, and high ventilatory pressure, all of these will be improved after using VV ECMO. Coagulopathy or bleeding. Anticoagulation is recommended but not required. It serves to protect the circuit from clotting, thromboembolism. Also, it decreases the incidence of bleeding. So the circuit also are heparin bounded, so it can improve blood circuit interaction. So ECMO-free anticoagulation can be used. But if the patient has active bleeding or something like severe active bleeding and uncontrollable bleeding, this is maybe relative contraindication. In patient with trauma and bleeding, isn't contraindication for VV ECMO. A likely VV ECMO is less incidence of stroke than VA ECMO, but there will be high risk for circuit thrombosis. Patients who will not agree to receive blood transfusion are challenges for ECMO. Sometimes we can't go for ECMO without multiple transfusion, and so this is a cost benefit, and we should discuss with them clearly for the using of ECMO. Prediction of VV ECMO mortality. There are many scores to predict the mortality, but mortality can increase with increasing SOFA score, increase the age of the patient, immunocompromised, acidosis, the patient spend more days on ventilator, more than 7 days, high ventilatory setting. RESP score can only predict survival to hospital discharge and doesn't predict neurological function or functional status. Some centers recommended to use RESP score equal or less than 3 for cases to be referred to ECMO. Besides elsewhere book, this is a reference for this lecture. Thanks. You can post your comments or question in the comment.